Thank you very much. Thank you very much for your very kind introduction. And let me thank Medea and for the wonderful organization and my friends from the POSEIDON group, Carlo, Sandro, Peter, and Robert for the invitation to this very nice and informative meeting. Okay, so let's go quickly through my disclosures. Nothing interesting here. I will not repeat what POSEIDON groups are, as you are going to hear about this for another day. But I want just to point out that in all the four groups, you can see here antral follicle count and AMH, antral follicle count and AMH, and so on. This is just to highlight the very important role of these two biomarkers when classifying using this new categorization. And you see here the magic numbers are 5 for the antral follicle count and 1.2 for the AMH. And I remember when I asked my friends of the POSEIDON group, where did these numbers came from? And they said, these numbers are coming from the Bologna classification for poor response. This has been published in 2011 on human reproduction. I was this guy, this young guy here. It was 12 years ago now. Because I was the younger guy of the group, all the literature search was in charge of me, unfortunately. And I was the one in charge with finding the best number for the AMH and antral follicle count to classify Bologna poor response. And you see here, we published these numbers, 5 to 7 for the antral follicle count and 0.5 to 1.1 nanogram ml for the AMH. Why this variability? This variability is there because at that time, this was the evidence we had. You must know that before 2011, the world of AMH researchers was divided in two, those using the DSL assay and those using the immunotech assay, which then was both by the Beckman Coulter. And in reality, the two assays gave different values for the AMH. This is just to say that 1 nanogram ml with the immunotech Beckman Coulter assay was corresponding to 0.6 when using the DSL assay. So in the end, we had papers, articles, reporting different absolute values when you use the AMH for predicting poor response. And also, there was some variability, I would say huge variability, because of the ELISA assay itself. You must know that ELISA assay is a manual assay, and so it is strongly dependent on the ability of the operator. Just to give you the idea of how much huge is this variability, you have here this Australian study that's very interesting. Authors sent the same blood samples to 10 different labs across Australia, and then they retrieved results. And you see here how huge is the variability between different labs. However, fortunately, the intra-lab variability was acceptable. So authors concluded, if you are going to use the ELISA assay, please use always the same lab in order to keep low, if possible, the variability in test results. The experience of the lab is indeed important when dealing with the ELISA assay. We did the same. I mean, we sent the blood sample from Modena University Hospital to Milan University Hospital, which at the time had good experience with the AMH measurement, and we found that in the end, for 70% of tests, there was an acceptable variability. But the story changed in 2014 when the Beckman Coulter company and the Roche company, they came together with an automated assay. Fortunately, they are using the same antibody. They are sharing the same AMH capturing antibody. but I'm going to show you some results when comparing the two assays. In any case, both the two companies disclaimed a very good clinical lab performance of the automation, very low coefficient of variability, and very low time to results. That's very important. 18 minutes. That's very important for those colleagues using the MH measurement in their daily clinical practice. And these very good results could be confirmed by independent groups. So now we have a very good and reliable methodology for the MH measurement. The automated system can be considered the gold standard when we want to measure this hormone. As I said, every time the assay for AMH has been changed, we in some way changed the absolute value of AMH in the test. And so every time clinical researchers went back to repeat always the same studies, we published the stability of AMH throughout the menstrual cycle. Many years ago, it was the 2004, 2005. But still, some researchers wished to find if AMH may be variable throughout the menstrual cycle when using the automated system. And I very much like this slide because this study, because you see here single value, single patients. Each line here is one patient for whom repeated AMH measurement throughout the menstrual cycle were available. It is quite clear that if you calculate, if you look at the mean levels of AMH is indeed stable. So yes, you can measure AMH on any day of the menstrual cycle, but it's quite interesting to look at individual values here. Each column is a patient and the variability of her AMH. So it is quite clear to me that when AMH is low, it is very, very stable. When AMH is below 3, AMH is stable throughout the menstrual cycle. But when AMH is very high, you see here 10, 12, 14, then you can have very huge variability. For example, in the last patient, the AMH ranged from 12 to 18 nanogram ml. But still, the information is carried to the clinician in the very right way. I mean, you are IVF doctors. If a patient is in front of you is presenting with 12 or 18 nanogram ml of MH, well, you understand this is a patient at risk of hyperresponse. So the great variability in MH levels in the end is not translating in a missed information. Still, some variability in MH is there. Why? Because you're measuring a hormone which is secreted by the ovary into circulation. Many things may change regarding, for example, hemodilution, which in the end may have an impact on what you measure. But variability is well recognized for all other analytes you are measuring every day in your clinical activity. So no wonder to see that some variability is still there for the MH. And as I always say, please remember, we are doctors. We have to interpret the data and the clinical tests we receive from our own patients. We compared the automated Roche and the automated Beckman assay, and we could find that the tests are not exactly the same, with the Beckman culture giving values for MH a little bit higher than what reported for the Roche. But we have published in the last few days an article in which we try to translate what is the clinical impact of this, and in the end, by using different nomograms, we could not find any relevant, significant differences in the dose of FSH you may calculate when using the two different assays. So to translate into a key message for you, I mean, in your clinical practice, you can use the two automated assays in an interchangeable way. What about the antral follicle count? Well, similarly to AMH, there was great improvement into the technology behind the antral follicle count measurement. In the last 20 years, there has been a huge improvement in the quality of the image so that we can really identify very, very small follicles in the ovaries of our patients. You see here, in the left side, you see there a nomogram, the graph for the normal range for antral follicle count we used in our office in 2006. And on the right side, you have what we are currently using, and you will see increased number of antral follicles. The reason for this is that nowadays we can identify more and more antral follicles into the ovaries. And this slide is very popular among clinicians with reporting on the left side an old image of the ovary in which sometimes it was really difficult to identifying and counting properly the antral follicles, and on the right side a very high quality image of the ovary with the possibility of identifying follicles as small as 1 millimeter. The problem we still have with the antral follicle count is that in reality there is no universal rule for counting follicles. And at least in our own hospital, we created this rule. We gave rules to doctors on how to setting the ultrasound equipment and on how to display the ovary onto the screen and how to identify and count in follicles. And at least in our experience, this may help in reducing the intra and the inter-operator variability, which still is a problem when we want to compare the antral follicle count in my hospital, in your hospital, in his hospital. Overall, the work done by companies and by doctors improved the diagnostic performance, increased the diagnostic performance of the two markers. You see here how the sensitivity, so the diagnostic performance of AMH and antral follicle count improved over the years. This is because of the improved technology behind their measurement. As I said, every time we change the way we are measuring hormones, the way we are measuring markers, there's a modification, there's a change in the absolute values for these markers. So is Bologna definition, are Bologna AMH and antral follicle count values still valid for identifying poor responders? This is a Dutch study published 3 years ago in which the antral follicle count has been measured with modern equipment and the AMH has been measured with the automated system. And you see here, authors could calculate these kind of values for predicting cancellation and poor response respectively. For cancellation, they found 4 antral follicles and 1.5 pmol, which is more or less 0.2 nanogram ml. And for poor response, they found 7 antral follicles and 4 pmol per L, which is more or less 0.6 nanogram ml. And what about this study? This is a very nice study, very well published, fertility and sterility, and it is a prospective, multicentric study in which the AMH has been centrally measured with the assay system, and they found 0.93 as the best cutoff value to identify poor responders. And they also report here 1.75 nanogram ml as a good value for predicting women with more than 15 antral follicles within the ovary. And finally, I'm showing you this article. This is a nice article because it's a prospective European study. All patients were included prospectively in 4 IVF centers, my own IVF center, Christophe Bloquil from Belgium, Nico Polizos from Barcelona, and George Griesinger from Lübeck, Germany. And we personally were in charge with the antral follicle count measurement, and the AMH was measured with the assay system. So you see here, the best cutoff value was 1 nanogram ml, which is 7.1 pmol per L, for the AMH with a very good sensitivity, 92% was the sensitivity. For the antral follicle count, the magic number was 6. The sensitivity was a little bit lower, but still acceptable. It was 84%. Then we have the retrospective study by Sandro, already presented by someone else. 3 centers here, Brazil, Turkey, Vietnam. The design is retrospective, so this means that they analyzed historical data for the AMH, and probably AMH was measured with the old ELISA assay. And so this may explain why they found quite different results. You see here the magic number again is 5 for the antral follicle count and 1.27 for the AMH, but you may agree the sensitivity was a little bit lower. It was close to 66% with the rock area under the curve, which is below 0.8. And also the calculated values for suboptimal response, 2.97 for the AMH, which is probably, to my experience, a little bit higher for identifying women with a suboptimal ovarian response. At least in our clinic, we use 2.5 nanogram ml to identify women at risk of hyper response. But the good news is that the concordance between the two tests was good. As Carlo mentioned before, sometimes you may have some discrepancies between AMH and antral follicle count. We can go in depth in this if you want during the discussion section. And so yes, sometimes you have good antral follicle count and low AMH and vice versa. But in this study, in this article, the rate of concordance was good, so that according to their own classification, 3 out of every 4 patients were classified under the same group, and virtually all patients with discordant biomarker results remain within the broad category of low prognosis. So, dear colleagues, few take-home messages. AMH and antral follicle count have been relevant objective of clinical research and had a very quick translation into the clinical practice. This led to great interest by companies who worked on the methodology behind their measurement, and because of this improvement, there was an increase into diagnostic performance of these 2 markers, especially for the AMH. The automated assay represents an expected improvement for the AMH measurement. It's associated to reliable results. The time to results is very low, and also costs are expected to be reduced. This may permit a wide diffusion of the assay itself. Huge improvement in the technology behind the antral follicle count measurement led the researchers to continuously revise reference range for this marker, but still we wait for consensus on what is normal at any specific age. When using the Bologna classification, at least, an AMH of 0.91 nanogram ml seems an appropriate cutoff when the modern automated assay is used. And when using the POSEIDON classification, the good performance for AFC 5 and AMH 1.2 has been confirmed, at least in the retrospective multicentric validation study. However, there remains room, I think, for a new prospective study specifically addressing this issue. Thank you very much for your attention.